I'm really honored to have been invited to speak at the Lenten Noon Forum, and particularly as I come, in a sense, almost sight unseen, despite the long association that my wife Nancy and I have had dating back to 1978, actually, so it's been 34, almost 35 years. But considering the quality and expertise and experience of the other Lenten Noon Forum speakers, I feel a bit like I might be in a bit of an imposter. But desiring doing, the social determinants of health, just exactly what is the connection? Most human beings have, upon reaching early adulthood, wishes, hopes, dreams of what their life will be like, of what they can do with their life, and who they will become. To borrow from other themes in this series, these thoughts and ideas follow the birth and growth of childhood and the loneliness and longing of adolescence. They come long before wisdom, wandering and wondering of seniors and the end-of-life frailties and farewells. But what factors allow human beings to achieve even fragments of their wishes, hopes, and dreams? And where do their wishes, hopes, and dreams come from? What are the forces external to the individual that will determine the path their life may take? My theme today is essentially about the distribution of resources and about justice. That is justice in its ethical meaning of being fair and reasonable. And so it is about those that live in the shadows of desire and doing. It is about mind-body connections, but how human civilization itself matters to health. On the surface, much of what I may say may appear to be more secular than spiritual, but to me, health is a very deep spiritual condition. As I said, most human beings have hopes and dreams of what their life will be like, but not all. Mary is a 27-year-old Aboriginal woman, the mother of two, Sam, age 3, and Alice, age 2. Both of them are currently in foster care, taken from her a few months ago because the ministry concerns that she couldn't manage their care. She struggles with alcohol. She misses her children, but she's just got out of a stabilization program. She's trying to find housing so that she might be allowed to get them back. She has a grade 8 education and has never had more than a part-time minimal wage job. She lives on social assistance, but it barely covers the cost of less than adequate housing, leaving little for food. In fact, she frequents a local food bank quite regularly. There's little hope of more income and limited support to now be educated to even an average level or trained for any job that pays more than the minimum wage. Mary's estranged from her siblings who live on a reserve in the interior. Both her parents struggled with depression and alcohol. Her father committed suicide when she was 5, and her mother died from liver failure, the result of alcohol abuse. Mary smoked since she was 13. She has hepatitis C, which she picked up from her on-again, off-again boyfriend who's now in jail. Mary is not a real patient, but she could be. For her struggles are really not all that dissimilar to many people I have encountered in my professional lifetime. And I have seen patients with every single element that I attributed to her. The origin of the name Mary is obscure, but it may be from the Greek, and means in that language bitter. And who would blame Mary if she was bitter? Imagine if you were Mary. So I want to say something about who I am professionally. Larry introduced me, but I want to just fill in a few other details. My understanding of health does indeed come from a large body of experience. For a third of a century, I practiced as a family physician in a suburban, and especially in my early years, was really a partly rural community, which now is referred to as the West Shore. I also work part-time for VIA as the medical director for residential services. But during the time I've been in practice, this was interesting to calculate, but I've had about 175,000 face-to-face patient encounters. I've met about 10,000 people of all ages. I currently have patients from really all corners of the globe, including the United Kingdom, Ireland, France, Germany, Netherlands, Italy, Slovakia, Czech Republic, Poland, Ghana, South Africa, Iran, Egypt, India, China, Japan, Korea, Thailand, Vietnam, Indonesia, and the Philippines, Australia, New Zealand, Venezuela, Mexico, Cuba, Jamaica, Trinidad, and the United States. They all live in Victoria. My youngest patient is 4 days old. My oldest is 103. I still deliver babies, look after disabled adults, the elderly at home and in residential care facilities, students and teachers, professionals, laborers, businessmen and women, wives and children, and single mothers and single fathers. What makes family medicine unique amongst all medical specialties is that it affords the opportunity to interface with every age and stage of life, every day. I've managed members of 4 generations in the same family at the same time. I've managed members, or cared for members of, I've delivered babies that I've delivered, which is a bit of a palindrome, but it's true. I've watched unfold the drama of life from generation to generation, and I've witnessed firsthand great joy and great sadness and seen those things happen to different people on the same day. It's truly a privileged vocation. Now, as a family physician, my role is within the healthcare system, generally as a provider of what we refer to as primary healthcare services. Healthcare services, and especially primary healthcare services, are a social determinant of health. In this context, primary means first, as in the first place that a patient might go to seek healthcare services. Ideally, the primary healthcare system includes family doctors, nurses, nurse practitioners, and other healthcare professionals who work together to create a comprehensive basket of needed health services. Fragmented, parallel, and poorly integrated health services are usually not nearly as efficient, and unfortunately what we see in many instances today. It's also confusing to the public. There is international evidence that a robust primary healthcare system correlates strongly with positive health outcomes. It's proportionately less expensive than secondary, tertiary, and quaternary services, and it provides most needed health care to most of the population most of the time. Countries that have traditionally focused on high-intensity specialty services have often failed to deliver across-the-board best health outcomes, often because many of their citizens are systematically denied access to those services. Nowhere is the healthcare system more valued or scrutinized as a public good than in Canada. But despite spending more on healthcare per capita than most countries, we are now achieving only modest health outcomes. So although healthcare has a significant positive impact on health, it's but a single determinant of health, and frequently not really a major one. Virtually daily, I observe the impact that other factors have on the health of individuals. Without health, there is a huge barrier to desire and doing. For some, the primary desire may simply be health itself. In Mary's case, what chance did she ever have of having health? For better or worse, health may be largely determined even before reaching our prime years, and our experience in the prime of life may have a great influence on our waning years, or even whether one actually gets there. As we are frequently told, the path to health is pretty simple. If you eat the right foods, don't smoke or use drugs, drink only in moderation, and exercise regularly, you will achieve good health. An ounce of prevention is worth a pound of cure, or is that 30 grams of prevention is worth 454 grams of cure? Would it help Mary to tell her this? Should we let her know that the true solution to her problems would be to quit smoking and drinking, to exercise, and to eat better? Thomas Jefferson said that all men are created equal. Leaving aside that he may have excluded women, children, and slaves from his pronouncement, it's clear that when it comes to health, that people are certainly not all born equal. As I continue, I want to define a number of terms that I have and will be using. In 1946, the World Health Organization defined health as, quote, a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. By that definition, I wonder how many can say at any given time that they truly are healthy. Health care has been defined as, quote, the prevention, treatment, and management of illness and the preservation of mental and physical well-being through the services offered by the medical and allied health professions. This definition covers only 2 of the 3 dimensions included in the World Health definition of health. It includes mental and physical well-being, but it actually excludes social well-being. And that exclusion is why, for all the resources we spend on healthcare, we struggle to see results. Health outcomes, a term that I've already mentioned, refers to a change in the health status of an individual, a group, or a population which is attributable to a planned intervention or series of interventions, regardless of whether such an intervention was intended to change health status. Now, a determinant is a factor that directly governs the nature of an outcome. According to the World Health Organization, the social determinants of health are the conditions in which people are born, grow, live, work, and age, including the health system. These circumstances are shaped by the distribution of money, power, and resources at global, national, and local levels. The social determinants of health are mostly responsible for health inequities, the unfair and avoidable differences in health status seen within and between countries, end quote. So if the question is nature versus nurture, then the social determinants of health represent nurture. Although health can rarely be explained on the basis of either genetics or environment alone, as we are all aware. So with all of this in mind, and considering the World Health Organization definition of health, how are we doing? According to the Canadian Institute of Health Information, more than 40% of Canadians report that they have at least one of 7 common chronic conditions: arthritis, cancer, chronic lung disease, diabetes, heart disease, high blood pressure, or a mood disorder, but not including depression. So 40% are not healthy before we consider other common conditions, including depression, which is common, and before we consider social well-being. Unlike healthy lifestyle choices, individuals do not, by and large, choose their social or community network. We are brought up within the context of and with access to the resources of our own society, our personal community. The concept of society really is multi-layered. In the local sense, society actually represents a group of people with whom an individual shares their life. It usually includes family as well as others with whom one has enduring relationships. In this sense, each of us has our own society, as we each have a unique set of relationships, often differing even from those that are close to us, perhaps because of work differences. Beyond our local society, there are broader groups. Collectively, we may define regional, national, and even global societies, and further refine societies along political, ethnic, religious, racial, or other lines. As far as the social determinants of health are concerned, interventions can be applied to any of these societies, and health outcomes can be measured within any identifiable group. And I know there are exceptions. There will be unhealthy people in the least risky groups, and there will be healthy people found in groups that face the greatest of hardships. But they are the exceptions. Social determinants of health are not independent measures of environmental factors. They are closely interdependent, and they cannot be viewed in isolation. Each determinant is like a strand within a cloth. According to Juha Mikkonen and Dennis Raphael in their publication, The Social Determinants of Health, The Canadian Facts, there are 14 social determinants of health, at least in the context of Canada. Health services, as I've mentioned, is but one of the 14. It's one of 14, and yet in British Columbia we spend 40% of the annual budget on health services. What I would like to do now is to consider each of the 14 social determinants of health that they have listed. The first is income and income distribution. Income may be the most important social determinant of health. It's not to say that money buys happiness, nor necessarily health, but having sufficient resources to help ensure access to many things that are critical to good health, such as food security, housing, and general living conditions, make a difference. Psychological functioning is generally better without the stress of concerns about personal resources. There are probably two aspects of income to consider. That's income that's available to the individual families, but also income distribution across populations. Wealth does correlate with longevity, while poverty costs people years of life. A report from the Organization for Economic Cooperation and Development, the OECD, indicates that Canada is one of only 2 of the 30th wealthiest nations in the world to have an increasing gap between the rich and the poor. This means we have increasing numbers of rich and increasing numbers of poor, with the middle actually shrinking. Over a 20-year period from 1985, the poorest 30% of Canadians had no net worth, and they actually had greater debt by 2005. For the top 10% of Canadians during the same period, their net worth in constant dollars rose by $659,000 to $1.2 million. During the same period, the richest 20% of families in Canada had an increase in wealth and incomes, and the bottom 60% actually saw their incomes fall when measured in constant dollars. And to appreciate the significance in terms of health, men living in the 20% of richest neighborhoods live 4 years longer than those in the poorest 20% of neighborhoods. For a woman, the death rates were 28% higher in poor neighborhoods. And one of the major reasons for that is both diabetes and heart attacks are much more common amongst the poor. The second determinant of health is education. It's a critical social determinant because those with higher education are healthier, not just because they attained that higher level of education, but that there's a correlation between education and income, employment security, working conditions, and the fact that education empowers them to have better access to all kinds of resources, including retraining should the job market change. People are able to reinvent themselves in the context of a rapidly changing environment. Half a century ago, a high school graduate might have expected to have 1 or 2 jobs during a lifetime. Today, that's anticipated to be at least half a dozen or more. For the most part, Canada scores well in education. The problem is that well-educated families tend to have children who also become well-educated, which is not a problem, but the poor do not. And public policy, which pays only for education through grade 12, creates a very significant barrier to higher education for the poor. Children whose parents have no post-secondary education perform much more poorly than those whose parents have had at least some post-secondary education, and current tuition fees essentially preclude post-secondary education for many low-income families. By contrast, in Finland, where all education is publicly funded, all post-secondary education is publicly funded, the children of poorer families can and do access higher education, and at a level greater than the children of richer families in Canada, such that on test scores, the children of poorer families in Finland actually outperform the children of richer families in Canada. The third social determinant of health that they consider is employment and job security. Now, employment means income, but as a determinant of health, it's even more important. It creates a sense of identity and a structure to life that contributes significantly to health. Conversely, unemployment leads to multiple stresses, including loss of income, social deprivation, poor coping behaviors, such as drug and alcohol abuse. When there was a significant change in government cutbacks in this, that have particularly affected this city in the 1980s, I well remember that there was a substantial and sustained increase in the number of people that came to visit the doctor. Not directly because they were unemployed or struggling with employment, but because they were actually ill. In a time of undersupply of doctors as it was then, it seemed ironic that a loss of job security for some actually increased the job security for others. Job insecurity in the form of part-time work often leads to people working 2 or 3 part-time jobs and stresses with working very long hours and juggling the needs of employers. That is a very common phenomenon amongst young people now. And illness could threaten the loss of more than one job. From 1976 to 2003, there was a nearly 300% increase in the number of people working multiple jobs. On the OECD Employment Protection Index of Rules and Regulations that protects employment and provides benefits to temporary employees, Canada ranks 26th out of 28 reporting nations. The fourth social determinant of health is employment and working conditions. People generally spend a great many hours at work, so the conditions there will almost certainly impact health. One of the most common identifiable reasons for visiting the doctor is workplace stress. And who's most likely to be subject to stress in the workplace? Those with a lower income and less education. In addition to poor pay, pressures to produce and lack of respect from superiors are much more likely. This imbalance often leads to a sense of underappreciation, and there are a plethora of associated illnesses. Depression and cardiovascular disease are the most common. Data in recent years has confirmed that Canadians perceive that they have less freedom when it comes to the workplace. In fact, only a minority feel they have control. More than a third report work-related stress due to increased demands or long hours, or both. More than a third of men work over 40 hours a week. And the workplace, often driven by large parent companies, does little to engender a sense of trust between employer and employee. Some are required to get a doctor's note to excuse them from even 1 or 2 days of work, even though they are not paid for the time off. And on minimum wage, they're even expected to pay for the note. Only Japan and the US have fewer mandated holidays and vacation time than Canada amongst all the OECD nations. The fifth social determinant of health is early childhood development. The experiences of early childhood have an immense effect on health, both at the time of childhood, but often for a lifetime. The experiences impact at a biological, psychological, and social level, striking at the very center of what health is. Childhood experiences seem almost to imprint on the individual, and that imprint does not go away. Children with negative experiences, even if they seem to cope well at the time, often face great health challenges in the future. Psychological challenges for sure, but social and biological challenges as well. I've spent countless hours counseling adults who live with a psychological pain whose roots are deeply embedded in their childhood. They often have stunted life paths with multiple failed relationships, chronic insomnia, anxiety, depression, addictions, limited education, and they struggle to hold a job. Through no fault of their own, they actually tax the healthcare and social welfare systems very significantly. Children now are facing ever-increasing challenges as often both parents have to work, often at low-paying jobs, just to make ends meet. And this means surrogate caregivers, and the poor often have limited or no access to any regulated childcare. 15% of Canadian children live below the poverty line, ranking Canada 20th of the top 30 richest nations in the world. The influence of parents, caregivers, family, and community are of great importance in ensuring a truly loving environment. That love can be enduring and remain with the individual for the remainder of their life. Conversely, an unsupportive environment creates anxieties and uncertainties that reverberate for decades at an incalculable cost to society. More than 12% of children in the lowest socioeconomic groups in BC have fair to poor health, as opposed to only 1% in the highest socioeconomic groups. So a child living in a poor family is 12 times more likely to have ill health than a child in a rich family. And to compare Vancouver Island with the rest of BC, there are 32% more children in care, 18% more child abuse cases and 24% more teenage pregnancies and 28% more children and youth relying on social assistance on Vancouver Island compared to the rest of BC. The sixth social determinant of health is food insecurity. Now, food is a basic human need. Food insecurity refers to the inability to ensure access to clean and nutritious food. It's estimated that 9% of Canadian households, or 1.1 million people, are food insecure, and the majority of these households include children. It's most common in lone mother households and Aboriginal households, whether or not they have children. And food insecure households consume fewer fruits, vegetables, and dairy products, and they're at risk of vitamin deficiencies. The incidence of chronic disease has been shown to be higher in these households, including diabetes, that's 80% more likely, heart disease, high blood pressure, 60% more likely, and even food allergies. And the ability of the household resources to manage these diseases when they do occur is obviously very poor. The effect of malnutrition on children has long-term effects on both physical and psychological development. To compound food insecurity even further, healthy foods such as milk, fruits, and vegetables are often much more expensive than poor quality foods. Nearly 1 million Canadians currently rely on food banks at least once a month. And in the United States, it's currently estimated that 49 million face food insecurity on a daily basis, affecting 1 in 4 children. Ironically, because the low-calorie foods are cheaper, they also often suffer from obesity because they are ingesting the poor quality but high energy foods because of their poverty. The seventh is housing, and it should be abundantly evident in downtown Victoria that housing, or the lack thereof, is a threat to health. The availability of housing correlates strongly with the lack of economic resources. How does it affect health? Well, poor quality housing is associated with overcrowding, the transmission of respiratory and gastrointestinal illness. Relatively high housing costs decrease the economic resources available for food and clothing. And poor housing conditions are associated with poor heating, mold, poor ventilation, lead, vermin, and stress. And stress in these circumstances is often associated with substance abuse, further exacerbating poor health. And on Aboriginal lands, many houses often lack basic sanitation and clean drinking water. And the effects on health are even further compounded because housing costs often leave little in the way of other required resources. Rents in cities have far outstripped the rate of inflation in other Canadian cities in the past 2 decades. And in the major cities, about 1 in 5 households spend more than half their income on housing alone. The eighth is social exclusion, and that refers to specific social groups who, for reasons beyond their own control, are prevented from fully participating in life. They cannot influence, at least for the most part, their own social conditions. Aboriginals, people of color, recent immigrants, women, and people with disabilities may each to some degree be marginalized and excluded socially. Access to resources, cultural, educational, and healthcare, just to name a few, is limited in some way. They're more likely to be unemployed, and those that are unemployed are more likely to be earning a minimum wage. That are employed are more likely to be earning a minimum wage. They're often segregated into specific neighborhoods, visibly identifying them as being different, being outcast. 4 aspects of exclusion have been identified: denial of participation in civil affairs, denial of social goods, exclusion from social production, and economic exclusion. All of these factors endanger the health of individuals. And there's a disturbingly increasing trend in labor markets in this country and others that has meant that a disproportionate number of low-paying jobs go to Canadians of color, women, and recent immigrants. And this means they're further isolated from other Canadians. The employment rate for recent immigrants is nearly double that of the general population, despite fewer of them few of them are not even part of the labor force and therefore aren't counted. and their exclusion from the mainstream of society appears to be a major factor in increased rate of chronic diseases, again, diabetes, respiratory, and cardiovascular disease. The ninth social determinant of health is the social safety net, and it refers to a variety of benefits and programs that are particularly important in supporting citizens at critical times in their life, both expected and unexpected. Child rearing, education, entering the labor force, and retirement are all expected. Divorce, unemployment, accidents, and infirmity are not. All of these critical times can potentially expose people to poverty, and most of these events are, by and large, outside the control of the individual. But out of the 30 OECD nations, Canada ranks 24th in supporting a social safety net. It's 26th out of 27 in terms of early childhood education, 26th out of 29 for seniors benefits and supports, 22nd out of 29 on social assistance payments, 23rd out of 28 on unemployment benefits, 27th out of 29 for benefits and services for people with disabilities, and 25th out of 29 for supports and benefits to families with children. The requirement for a social safety net differs across the nation as well. If we consider Vancouver Island, for example, in Lake Cowichan, 7.3% of children were living in families on social assistance as compared to 1% in Saanich. The 10th is health services, which I have already mentioned, but many in the country speak praises of our single-payer system of full coverage for medically required services. But actually, by the time Canada actually only ranks 22nd out of 30th in OECD nations in its public funding for health care. How can that be if we are fully funded? And it's because while medical services are fully covered, the cost of medications and other services frequently are not. Many are covered by third-party providers, but these services are usually not available to the poor. They're much more likely to be available to those that already have. So the poor, unemployed, part-time workers, and seniors often are shut out. We really do have a two-tiered or maybe multi-tiered healthcare system, whether or not politicians want to label it as such. Access to primary and specialty services are reduced for the poor compared to the rich, though it's technically forbidden by the Canada Health Act. Many rich are able to access private imaging studies within Canada, and they're able to travel abroad for care, something not available to the poor. Wait times for services, including seeing a doctor to get care, have increased dramatically in recent years. And because of the increased burden of suffering from illness experienced by the poor, they are disproportionately affected by those wait times. The 11th is Aboriginal status. And in Canada, that matters greatly when it comes to health. I've mentioned it's impossible to separate social determinants of health from each other, and this is nowhere truer than with Aboriginals. Income, education, employment, housing, food insecurity, early childhood development, social exclusion, and the provision of health services are all negatively impacted by being Aboriginal. Both those living on reserves and to a significant degree those living off reserves. Suicide rates are nearly 6 times higher in Aboriginals compared to non-Aboriginals, and more than a quarter have problems with alcohol, and 1 in 5 are depressed. The United Nations Declaration of the Rights of Indigenous Peoples included articles which would ensure improved economic and social conditions, the right to obtain the highest level of health, and the right to protect and conserve their environments. The UN General Assembly passed that declaration in 2007 by a vote of 143 to 4. Canada was one of the 4. The 12th is gender. Women are adversely affected by social determinants of health compared to their male counterparts. The primary contributing factor relates to the responsibility for raising children. As a result, they're more likely to be working less than full-time and are likely eligible for fewer benefits, including unemployment benefits. And moreover, a greater number of low-paying jobs are filled by women. And policy decisions that affect social safety nets are almost certain to have a greater impact on women than on men. Interestingly, despite the fact that women have a longer life expectancy than men, they actually have a greater likelihood of long-term disability and suffer from chronic diseases more than men. It is the extreme form of social exclusion and a higher accident rate that appears to be the major contributing factor to men's decreased life expectancy compared to women. Young men are much more likely to be in jail, and young men actually are victims of social expectations of behaviors of young men. So in a sense, both men and women actually do suffer ill health that are associated with societal policies and expectations that are directly related to gender. And not insignificantly, gay, lesbian, and transgendered Canadians also experience significant discrimination, which leads to stress and adverse health outcomes, despite the advances in legislative protection afforded in recent years. The 13th is race. And racism in Canada is perhaps more covert than other countries, but it exists and it impacts negatively on the health care or the health of its victims. Even institutionalized racism still exists to a degree, though its social acceptability is at least on the wane. However, it is really internalized racism, which occurs when those stigmatized internalize the message of institutionalized and personally mediated racism that is deeply detrimental to health. Statistically, Canadians of color have higher rates of unemployment and they're more poorly paid. And data shows that non-European immigrants to Canada show deterioration in their health over time. They experience more mental health issues and are more challenged with both housing and food insecurity than most Canadians. Non-European immigrants are 50% more likely than the Canadian-born population to visit a doctor. The 14th and final is disability. And the health of the disabled is largely determined directly by public policy. How willing is society to provide for those with physical or mental disabilities who could not ever achieve the supports they require? How integrated are the disabled into society? Less than 5% of children are disabled, but nearly 12% of adults up to retirement are disabled, and nearly 40% of older adults are disabled. Nearly half of those in the working group are not employed at all. They rely on social assistance. Many employers are reluctant to provide any on-the-job accommodation for the disabled. Canada, one of the richest nations in the world, ranks 27th out of 29 in public spending on the disabled, as I mentioned earlier. So the health of the individual is not really the sum of the fortunes of biology combined with personal fortitude and ambition, admirable as that might be. We are rarely truly self-determined, though there are many who have overcome remarkable odds. Health is much more often related to the alignment of the fortunes of social circumstance. If we are to improve the health of our communities, of our nations, and of the globe, this must be taken into account at a deep political level. The examples that I've cited here, many from Mikkonen and Raphael's paper and a 2006 discussion paper from the Chief Medical Officer of the Vancouver Island Health Authority, reflect the local and Canadian examples of the effects of the social determinants of health. But the discrepancies between the rich and the poor often pale in comparison to the discrepancies between the developed world and the third world. I would suggest that the reasons that the Western world struggles to get it right in the third world are the same reasons for the discrepancies in the first world. If there's a theme in the social determinants of health and the data that I've mentioned, it's that the rich truly are getting richer and the poor are getting poorer and are suffering for it. We will always have rich and poor. We as Christians generally consider that we have a duty to attend to the poor, but the resources of the rich can't simply be extracted to look after the poor. That in fact might be counterproductive and it won't happen. But the number of poor is outstripping the ability of charity to support the poor. So the question remains, how can the gap between rich and poor be bridged in such a way as to allow the poor a fair opportunity to thrive, to overcome their disadvantage? There can be no doubt that the social determinants of health are on the radar of policymakers. With an upcoming provincial election, within the last 6 days, 3 headlines from the Times columnists this week. BC to cut funding for adults with disabilities. Plan prescribes doctors for all. Province wants more daycares in school. They're all social determinants of health. The greatest barrier to change is that policymakers, in my view at least, is that policymakers fall to the temptation of self-interest, and they are often in a conflict of interest. And when I say self-interest, they're really motivated to maximize the interests of the group that they perceive has elected them. Policymakers may be the agents for those that place them in power, and they're likely to come to the decisions really based on their own class and their own socioeconomic group. So what of Mary? Well, the Greek origin for her name may mean bitterness. There's also a school of thought that the name is of Egyptian origin, and it might mean beloved or loved. Can Mary be loved? What would a just world look like for Mary? I want to reflect a little bit on philosophy and ethics to conclude. And I want to define a term, rational egoist. And what a rational egoist, according to the 19th century English philosopher Henry Sidgwick, rational egoism is a procedure by which a person determines what is right for them. So in the weighing of the consequences of a decision, they weigh pleasure and pain to come to a decision, and an agent will always in that situation choose which will bring them the most pleasure as an individual. John Bordley Rawls was born in February 1921 in Baltimore, Maryland, the son of a prominent attorney. He was influenced by a series of events of tragedies in his early years. He contracted diphtheria, and one of his younger brothers was exposed to him and died. A year later, he developed pneumonia, and yet another younger brother came into the room, contracted pneumonia, and died. As a young man, he was educated at an Episcopalian preparatory school in Connecticut, and he subsequently attended Princeton. He actually then considered becoming an Episcopalian theologian, but ultimately, this was 1943, he joined the U.S. Army, where he witnessed the atrocities of war, and in particular the aftermath of the bombing of Hiroshima. Following the war, he returned to his studies and ultimately became a moral philosopher, where he taught at Christ Church, Oxford, and ultimately at Cornell University. He died at the age of 81, but he left a legacy, which was his paper, A Theory of Justice. And part of the theory was based on the idea that most people are rational egoists. I will not justify or justly describe his theories in 7 sentences, but here's a brief paraphrased summary. Imagine a world much like the world we live in. There are rich and poor, able and disabled, educated and ignorant, powerful and powerless, people of every color, class, and creed. And you, a reasonable person, perhaps a rational egoist, will live in that world. But imagine you must construct the moral rules under which all people live. But you will do so with no knowledge of what your own abilities will be, what your tastes or position in the social order of that world will be. You will have no knowledge of what your burdens or benefits might be. And as you create the moral rules, you will decide based on your own self-interest, but from behind that veil of ignorance, without knowing who in the world you will be. Imagine a more spiritual civilization. Imagine justice. Imagine you are the other. Imagine you are Mary. Imagine.